So today we're here with Dr. Kevin Khalsa from Ortho, Arizona. So happy to have you on the pod.
Thank you.
So first things, you're an orthopedic surgeon.
Right.
What really got you into medicine? What made you want to be a doctor?
So initially, I never actually wanted to go into medicine when I got to college. When I got to college, I wanted to go into culinary school.
Really?
I wanted to be a chef.
Oh, that's awesome. That explains the foodiness.
Yeah, but I realized how hard it is to be a chef. Then I switched my tracks and wanted to go into veterinary medicine. Mm-hmm. And I didn't realize I just absolutely did not like anything but dogs. So that was also X'd out. Mm-hmm. Then I actually switched majors the fourth time, and I tried to go into diplomacy because I wanted to do international diplomacy. And classes were very hard. So I found my fallback was pre-med.
Okay.
And when I finished college at UCLA, I realized I like talking to people, and I think I can talk and help people at the same time. And I like working with my hands. So that kind of transitioned me into just getting into medicine. Mm-hmm. When I went to med school, orthopedics was not the track I was planning on doing. All my family, I have some doctors in my family that are like medicine doctors, nephrologists. Mm-hmm. So it was going to be one of those other fields, like either dermatology, nephrology, medicine, or ER. And so that's kind of how I got into medical school. But then when I got into medical school and I started going to my rotations, I realized that unfortunately no other field allows you to work with your hands and also use your brain as much as orthopedics does. And in a way, you're completely in control of the outcomes.
That's awesome.
Most of the other fields, you have to give a medicine, mm-hmm. then you have to wait. Then you have to wait probably a year to 2 years.
If it works, do additional labs.
Correct. Like in orthopedics, it's like immediate gratification. You put somebody back together, they feel great the next morning. If you do a terrible job, they'll feel terrible the next day. If you do a great job, they'll feel great the next day. And so that kind of instant gratification is what I ultimately drove me towards orthopedics in general.
You wanted to say, like, if I do something with a patient, I want to know that it helps them. And
I want to know pretty fast.
Yeah,
correct.
pretty
Yeah.
fast.
And in nephrology and medicine, you don't get to have that chance because it's heart disease or kidney disease. You have to wait 6 months to a year to see if the labs change or the kidney function improves. In orthopedics, it's overnight.
That's awesome. So you wanted to be a chef, but decided to pick something a lot easier because it was too hard and went to orthopedic surgery. That makes sense.
Yeah, yeah, exactly. And then went to spine because that was the easiest one.
So, as far as orthopedic surgeon, you guys love acronyms probably more than even pain doctors do. So I'd love to ask you what some of the acronyms are and what they mean and what they're doing. So, let's go like an ALIF. What is an ALIF?
So ALIF stands for anterior lumbar interbody fusion. That basically, the running joke is orthopedic surgeons are not the smartest people in the medical school. And so everything for us is pretty simple. So it's anterior, which is in the front, lumbar spine, interbody, between two bodies, mm-hmm. fusion. That's pretty much all it stands for.
So when people say I need a lumbar fusion versus mm-hmm. I need an ALIF, it's essentially the same thing. It's just the approach is getting more specific.
Correct. Like you try to figure out exactly where the pathology is. So, somebody says, well, I'm having nerve pain down my legs. You have to look at the MRI and try to correlate, is the pathology in the front? Would it be best served by doing an ALIF? Or is the pathology on the back? So can I do a TLIF, which is a transforaminal? Or can I do a lateral, which is coming from the side? So it just depends upon the MRI and what the patient's symptoms are.
So all of the lifts, O-LIF, X-LIF, mm-hmm. A-LIF, T-LIF, it's really a lumbar fusion. It's just the approach is the difference. So A is anterior, X is lateral, right? T is
transforaminal, which is posterior.
Okay, and then O?
O is another way of saying, so O and X are basically different company names. Mm. So X-LIF is what a company called Nuvasive came up with. It's still coming from the side. Mm-hmm. O-LIF is what a company Medtronic came up with. It's still coming from the side. Mm-hmm. So all these guys, and then D-LIF, mm-hmm. direct lateral, is also coming from the side. So basically O-LIF, X-LIF, D-LIF, they all mean the same thing.
On the company.
It's just coming from the side. It's just a company name.
So as an orthopedic surgeon then, what goes into making that decision? I think you touched on it a little bit, but if you go deeper, of when you're going to take an anterior approach or a lateral approach or a transforaminal approach for a fusion?
There are multiple factors. I mean, at this point in my career, that it's almost an algorithm as to, and the algorithm is pretty fast. When my advice to a lot of fellows, because I do teach a lot of courses where fellows and residents and new attendings come and learn, is you need to slow down, right? The key is to slow down and understand your patient and understand what they want. Before talking about surgeries, I think what you have to figure out is exactly why are you cutting somebody open. The number one criteria of medicine is do no harm. Yep. And I have to stress that to every physician I ever meet is you cannot walk into the field of surgery expecting to cut people open. That is not why you became a doctor. You became a doctor to convince them not to get surgery unnecessarily. And then, if they do need surgery, then you can go down the route of choosing the right path.
That's well said.
I think a lot of physicians, especially surgeons, we have this fallacy of like, oh, you're a surgeon, just cut me open. And a lot of surgeons get into the field of surgery thinking like, all I'm going to do is just surgery. And honestly, I tell my patients every day in clinic, 95% of what I do every day in clinic is to convince people not to do surgery. And then 5% is, yeah, you should do surgery. When they actually do need surgery, it's a combination of the pathology, the MRI findings, and the body habitus. If a patient is very, very heavy, I might not want to do an A-lift on them because coming from the front with a big belly is pretty hard. I might do a lateral on them coming from the side versus if somebody's super nice and skinny and they have something called foraminal stenosis, which is pinching of a nerve on the side. Oh, okay, that's easy. They're a healthy patient. They might want outpatient surgery. So then I can do a T-lift from the back and just get them home the same day. Because usually with the A-lift and a lateral, I keep them overnight. And with a T-lift, they can go home the same day.
And so it's just a big difference.
It's a big difference. And again, it depends upon the patient's body habitus, what they want, how many levels do I have to operate on, what we're trying to achieve. And again, I think
that's that algorithm that you were saying. It's like body habitus, what you're trying to achieve, how healthy are they, what's the condition that you're actually treating, transfemoral versus infusion. And so all of those things go into basically your internal algorithm, and you're like, okay, this is going to be the best outcome for this type of patient.
Correct.
So you said 95% of what you do is convincing people not to do surgery. So for people that are having, severe back pain, what are other options? I mean, we collaborate on a lot of patients with you. And, every patient we've sent to you, that's good. Every patient we've sent to you or that has come to us from you has always had nothing but wonderful things to say about you. So you're obviously a great surgeon, and patients really love the experience they have when they come to you. But as you just said, sometimes it's like, and it sounds like many times, surgery is not the first option for these people once they're coming to see you. So what are those other options that you would have people consider before doing those surgeries?
Great question. Obviously, we try everything non-operative first. The number one rule is you got to get your core muscles together, right? So physical therapy, home exercises, yoga, Pilates, whatever have you, you got to do that on the side. Again, fallacy of human nature is to say, I'm getting older, I'm going to slow down in my workouts. I'm sorry, that's actually the exact opposite.
Absolutely.
As you get older, you have to work out even more because your muscles atrophy a lot faster. So I tell my older patients, they're like, oh, I work out 5 days a week. I'm like, do it 10 times a week. You just have to do it more. It sucks to say that to them, but that's the honest truth. And the second is if they've done all that stuff, and I do have a lot of active athletes, amateur athletes that come to me for back pain, I send them to your clinics because then we get into the realm of pain management. The misnomer is, again, you're sending me to pain management, I'm going to be hooked onto narcotics. That used to be in the 1990s. That's not the case anymore.
Absolutely.
I think a lot of the doctors that I work with and that are in your company, we are trained not to give narcotics, and we're trying to achieve reduction of symptoms with non-narcotic treatments such as injections, epidurals, anti-inflammatories, muscle relaxants, nerve medications. So you have a slew of drugs and a slew of interventions we can do that your company does to reduce their pain. I think to your point is you have to just help people understand that, hey, listen, there might be a point where your pain's not going to be zero, but it'll be manageable. Right?
Like for us, one of the things that we really focus on is getting people not just pain-free, but really getting back to an active life. So you can have somebody, that's a 10 on a VAS that can sleep through the night, and you can have somebody that's a 10 that can't sleep at all. And that's one of the problems with the visual analog scale. And for those that don't know, visual analog scale is on a scale of 1 to 10, how bad's your pain? And in medicine, that's used a lot, but it's not really a good measure of pain.
It's not a good measure,
Right? And so that's probably the worst of what we have available, when we can instead look at how does your pain affect your life, your activities of daily living, which is a lot more useful for us because, again, if you do, let's say, a procedure like a spine surgery, and you had a 6 out of pain and couldn't do anything, and now after the surgery you're still a 6 in pain, but now you can do everything. Like, you're still a 6, and if we only use the VAS, it's like that wasn't effective. But if we look at the quality of life, massive improvement. If you
Correct.
talk to the patient, they're thrilled.
Yep.
And so again, it's so important to say, as we look at patients, it's, are we making a difference to the quality of their life?
Right.
And that's so much more important. So, I mean, you mentioned that. That's what we focus on. We love that you focus on that as well, which is, we believe that the best way we can help our communities is helping people to get their lives back, getting to do the things they love,
Right.
and returning people to their families. One of the most common phrases that we hear is, like, you gave me my family member back. Like, because of their pain, they no longer could be active members and participants in family activities. When you do those surgeries, when you do those procedures, and you can get them back to that, I mean, that is life-changing for the family and for the community.
I think like my usual pre-op visits are usually around the question is, because patients ask like, why am I getting surgery? And I tell them, I'm like, you're getting surgery because you want your quality of life to be better tomorrow than it is today. And that again helps you also tell people that they don't need surgery, because when patients come in with back pain and then you ask them, what do you do every Saturday, Sunday? Well, I ride 50 miles on Saturdays and I golf twice a week. And I'm like, well, that's an amazing quality of life. I wish I could do that. And so if you're having back pain and that's your quality of life, surgery's not going to change that. I would rather not do surgery on you so you can
Keep doing that.
Keep on doing what you're doing.
Yeah.
It's okay if you can manage the pain, just live through it. And then you have other patients that are like, no, my quality of life suffers. I barely can make it to the mailbox. Well, okay, you're going to benefit from surgery.
Yeah, I love that as a qualification for surgery. Like,
That has to be the
like, don't look at the
qualification.
pain. Look at what can you do and can't you do, and that's a lot better.
Yeah, I think
indicator.
like in medicine, especially because of the way our insurance companies are run and government is run, and because of the cutting of the costs and the reimbursements, physicians get into this mold where every patient is just a number, and it's gonna burn a physician. It's gonna burn them badly. You have to stop and put yourself outside and say, can I tell this person something that I would tell my mother and my father?
Yeah.
If you cannot do that, don't do it.
Do you feel like that's one of the reasons that we're seeing so much physician burnout? Like, that is a common theme right now in America, is physician burnout. Do you feel like that contributes to it?
100%. So I think there's a multifactorial reason why you get physician burnout. One is you have government/insurance companies cutting costs. So physicians are basically doing everything on volume, right? You're just
So trying to work harder to make the same
Correct.
amount of money.
Exactly. Two is you have the advent of the internet, which has good and bad. I personally love the internet. I love when my patients bring in wrong information, because then I can correct them and teach them. But with the advent of the internet, a lot of patients will end up doing things that are just not what I call kosher when it comes to spine surgery. And then they come back and tell us, hey, fix this. Well, at this point, you're like, should not have gone to Mexico. Like, don't do that. No offense to Mexico. Mexico has great medical schools too. But, there are certain modalities they offer in other countries, which I would not have my patients do. And the third is just like, we have always compared ourselves to our predecessors who used to make, X amount of money, and, they did things a certain way, right or wrong. And nowadays, a lot of the physicians are looking back at that and saying, wait a second, I'm doing the same number of cases / seeing the same number of patients, but hospitals are shutting down, my office is shutting down, I barely can keep my lights open. So I think that adds to the physician burnout.
Yeah, I think that a lot of people not in the healthcare field don't realize how expensive it is to work with health insurance.
gosh, yeah.
Like having a massive billing team just to get paid for the service that you're doing, and then you only get paid at 90% of what you should have. And
Right.
like, there's this whole thing of where, doctors are dealing with this administrative burden trying to see their patients. And I do think that causes a lot of burnout. But I like the theory that you said as well, which is because of the shift in lowering of reimbursement, doctors look at patients some doctors look at patients differently than they used to, whereas before it was what you said. I got into medicine to change lives, and I get
Right.
that. I can say, you have a problem, I can fix it, and they
Right.
feel better. You have to connect with the person to feel that. But when you're now trying to see twice as many patients because you're trying to make the same amount of money, you can't connect with the patients. And if you don't connect with the patients, and you're not creating those relationships, you will burn out.
You will burn out.
Because now you're doing all of this stuff just for the money rather than to change
Exactly.
people's lives.
Yep.
And I love that as a theory for why we're seeing so much burnout.
I think, one of the things I say at these courses I teach is, do not look at this to make money. If you got into medicine to make money, you will burn out, you will crash, you will suffer, you will fail. 100%. It's guaranteed. Medicine is not about money. Medicine has to be your passion.
Yeah.
If it's truly your passion, money will come, But if you're getting into field, for example, spine surgery, where you're physically changing lives, and once you cut somebody open, you cannot take it back.
Yeah.
So that onus is on you. So if you're going to do something to somebody's human body, you better be damn sure that that's something you can do for your mom, for your dad, because your mom and your dad ain't paying you.
Yep.
So if you can live with that overnight and sleep with that kind of responsibility, you can become a spine surgeon. If you cannot do that, don't offer them surgery and just walk away from this.
That's great advice.
And again, I have friends and families that are not in medicine. Mm-hmm. Talking about money, they probably make like 10 times more than I make. But would I trade places with them? Never. Even in medicine itself, I think what I do is what probably I see myself doing, even if I, went to a different universe and tried to work all over again. I want to be a spine surgeon. I love what I do. It's great. It's amazing. I'm happy with what I'm doing.
Well, that's the type of doctor you want to go to, is someone that loves what they do, right? So that's
I hope.
So that's great. So I do want to circle back on another thing you said that I think is really, really important. One of the most common things that we hear from patients is they come in and we take x-rays on them, and maybe they're in their 60s, 70s, and they have arthritis throughout their spine. And they come in and they say, my doctor told me that's normal for my age. And we say, well, that's not normal. Arthritis is not a normal state of being. It's common for your age, but that's different than normal for your age. And so we look at that, and I think it has to do with what you mentioned earlier, is as we get older, we are going to see an increased state of degeneration. Our body breaks down faster than it used to. We heal slower than we used to. But you can have, because we see it, you can be 70 with a very healthy spine.
Yep.
And so, the difference, if I had to simplify it down to the most common difference between why somebody at 70 has a healthy spine versus why somebody at 70 has an unhealthy spine, is their level of activity.
Right.
If they're active, if they're working out, if they're trying to go out and be active, those are the people that we see healthier versus the people that slow down, maybe they've gained some weight, they do these things, and that degeneration just takes over their body, and we see that. So what are your thoughts on that?
So it's amazing. So for all my non-operative patients, this is one of the questions they have is, I'll see patients with a beautiful looking spine at 70 with miserable back pain, and their spine looks immaculate.
Yep. And
they don't work out a single day. And then I see patients that work out every single day, have a terrible looking spine, but they have no pain. So, trying to put them into this Lego set or into a mold doesn't exist. And my theory is this: if you keep your core strong, you work out all the time, you're active, and your pain is manageable, you're not going to have the time to go see a doctor. So you have no idea what your spine looks like, right? Because you're never going to get an x-ray, you're never going to figure this out. And a lot of people are in that mold, right? The patients we see in metropolitan cities, because we live in metropolitan cities, is, with the advent of the MRI or the x-ray, the access to physicians in bigger cities, people just show up and say, hey, shoot an x-ray. And I'll shoot an x-ray and I'll tell the patient, how bad is your pain? They're like, I don't have any pain. And you're like, you have a terrible looking spine. I have no pain. Then why'd you get an x-ray? I just wanted to know. And that's the conversation where I tell them, Monk, listen, don't look at the picture. You're a healthy human being. You're active. Go enjoy your life, right? Why do you have arthritis versus another 70-year-old that doesn't? It's just up to Mother Nature's genetic destiny for you.
There is genetic.
You have a genetic destiny. You've had it, but you don't have symptoms. So focus on the symptoms and just go enjoy your life. Versus the other patients that have an immaculate spine and are in terrible back pain, those are the patients I sent to you. Because then I'm like, okay, now you have a good looking spine, you have atrophied muscles, you haven't worked out, you have gained a lot of weight, and you need a path to change all that.
Yep.
Right?
Back to activity.
So you have to reduce their pain so they can lose weight, exercise, be happier. And that's where I usually kind of break the algorithm a little bit, because a lot of times insurance companies will say physical therapy first, then injections.
Yep.
I think it actually should be the opposite.
Agreed.
Because you can't have somebody who's in miserable pain go to therapy, they get tortured and they suffer, and it creates a psychological trauma for them, and then they'll never go back.
Yeah.
So they go for 3 sessions and they waste their time, they waste everybody else's time, and then they just never go back. Versus you send them for injections first, temporarily control their pain, let them get into PT so they can engage more, have a good experience, and then they keep on doing it.
That is exactly along our philosophy. In fact, our chief medical officer, one of the things he calls that, he calls that the rehab window. He says that we oftentimes have patients that are so much pain that do they need physical therapy? 100%. Can they do it? No.
Right.
And so if you can get their pain in a state of like manageable, so you do an epidural, let's say, that radicular pain down the leg goes down, and now they go, okay, I'm better. And it's like, no, you're not better.
You need work to do.
Now we can actually strengthen your core and
Right.
stabilize and do that because you're not, put them on the table and they're screaming because they're in so much pain.
Correct.
Like, that's not the ideal state to do physical therapy.
Right.
But if you can say we can decrease the inflammation around that nerve, and why are we doing the physical therapy if the pain's lower? It's like, well, the reason we're doing the physical therapy is it has to do with treating the root cause.
Correct.
The root cause is when your core is not stable, it doesn't stabilize your spine, and then you can have injury, and then it gets inflamed. Well, we can take the inflammation out, but it's just gonna happen again and again and again.
Yeah.
So now the true cause of this is core instability. If we can stabilize the core, this doesn't come back the next time and the next time. And so, that's sometimes hard. Well, it's really hard for insurance to understand for some reason. But sometimes the patients are like, well, I was told that I need to do physical therapy first. And it's like, you do need physical therapy, like no doubt.
Right.
But if we can get this pain manageable, paired with physical therapy, that's really going to be what's going to give you long-term benefit, right?
Yeah, I think we need a paradigm shift of the way we look at medicine, especially for spine. I can't speak for other fields, but for spine, back pain being probably the number one cause where people go to the ER besides chest pain in this country. The amount of dollars we lose with unnecessary hospital visitations, where you can easily try to have a PSA where you kind of go around the country telling patients, hey, we have these modalities and you have to have insurance companies get on board with this.
Yeah.
Because insurance companies are incentivized not to approve all these procedures. This is where we need a complete paradigm shift to have insurance companies and physicians get together and say, no, we have to cut down the costs of medicine.
Yep.
We can't have people go to the ER for back pain. We have to have them come to the chiropractor, the therapist, get injections, reduce these visits, and that's how you'll save money.
Yeah, I think if we could do that, you'd lower the cost on insurance, and everybody would love the cost of insurance going down.
Yeah, it would be a phenomenal country.
You don't have to cut payments to things that are really important because you're not wasting it on things that are unnecessary, because people going to the ER for back pain is a waste of money. Now, it's not a waste for that patient who's in immense pain and they don't know where else to go. Yeah, of course, we understand why they go to the ER.
Right.
But that's not where they're going to get help.
Right.
They're not going. They might get temporary relief, but long-term help, it's going to be get to, as you just say, get to the pain doctor, get to the chiropractor, get to the physical therapist, get to the orthopedic surgeon. Like, go to where we're going to treat the root cause and get you, where you're going to have long-lasting benefits, rather than say, well, you're in the ER and we're going to be treating, a guy with a broken bone, and we're going to be treating a guy with, flu, and we're going to, like, all of these things at the same place. Like, it's not the ideal environment to treat.
It's not the ideal environment. And I think, like, there's a physical cost, obviously, which you look at dollar values of patients going to the ER unnecessarily, but there's also a social cost. Okay, so now you went to the ER with back pain. Somebody with a heart attack or chest pain or a PE now has to wait in the waiting area because somebody else is inside the ER. And so you have to start looking at this, like, kind of societal costs you're incurring.
That's a good point.
And it's a lot of money that we waste. And so I'm hoping, that as time goes along, physicians become much more active in these policies and start to make these paradigm shifts in every field.
Yeah. Well, I think it's a unique view because most specialists, you're in your lane and you don't have this bigger global view. That like what you're talking about actually is really wise in the fact that seeing how all of the different departments of pain work together, from the ER to the physical therapist to the chiropractor, the orthopedic surgeon, the neurosurgeon, when you take that more high level view and say, hey, there actually is connections of how these all fit together properly.
Right.
And it would save insurance money, it would save patients money, and it would be better, as you just said, for our communities, because resources can be dedicated to the right places for the right conditions, rather than wrong. I love that view. So I'm gonna change topics for a moment with you. One of the things that we get asked a lot from patients is, they'll say, I don't want to go get surgery for my spine because my friend got surgery and they still have pain.
Right.
So let's talk about that a little bit, because I think that is a fear that patients have, is I'm going to have spine surgery and I'm still going to have pain. We know it happens. Research shows that it happens. Why do people have pain after spine surgery?
So I'll start out by saying that I'll pretend for a second how, let's say you're a patient of mine, right? And you come in to see me reluctantly. And, you have, let's say, just back pain, but you have absolutely no leg pain.
Yeah.
I'm actually going to convince you not to do surgery. Because our studies have shown that if you operate on people for back pain versus for sciatica or leg pain, the difference is quite significant. So if you operate on somebody that has a lot of leg pain, the results are almost above 90% pain relief of the leg.
Excellent.
So what I tell my patients is, are you having leg pain or back pain?
Yeah.
And when they ask me what's the difference, if it's above your belt line, that's back pain. If it's below your belt line, like in your buttocks and your thighs and your calves, that's leg pain. If you have leg pain and we cut you open and we do surgery on you, and knock on wood, is successful, the chances of you improving are above 90%.
Wow.
However, if we cut you open and you only have back pain, the results are anywhere from 50 to 75%, but not more than that. So what I always ask my patients that have these statements that are like, hey, my friend got spine surgery and spine fusion, they're doing terrible. My question is, why did they get surgery?
That's a good point.
Well, they got surgery because they have back pain. Well, okay, me personally would not have offered them surgery, number one. Number two, how were they before surgery? Oh, they were so active. Well, then why did they get surgery? They want to be more active. That's not why you get spine surgery, you know? You're getting spine surgery because you're debilitated.
Yeah.
And your quality of life is miserable and you're trying to improve it. But if your quality of life is good, why would you get surgery? The third, more nefarious reason, which I personally, one of my core, like it makes me sad to even listen to this, is when patients say, the doctor told me I would be paralyzed if I did not get surgery. And that usually makes me the saddest.
Yeah.
Because that means one of two things. One is you didn't have a good conversation with your physician.
Yeah.
And because I usually ask, did you see the MRI? What part of your spine was affected? What do you mean paralyzed?
Yeah.
Well, I was walking, I was playing golf, and I went to my surgeon, and he told me if I didn't get surgery, I would be paralyzed. That doesn't make sense to me.
No.
Right?
Not in the lumbar spine for sure.
Not in the lumbar spine especially. So, the cervical spine, I totally understand. But in the lumbar spine, you're not getting paralyzed by the lumbar spine. So something doesn't make sense.
Yeah.
And then two is, were you listening to everything that the doctor was saying, or was the doctor communicating well? We miss a lot on bad communication. We miss a lot.
That's a really good point.
I call my patients routinely after surgery, even for months after surgery. I have this habit of, if I'm driving, and usually if my kids are in the car and they're screaming, I'll call one of my patients just for fun, just to check up on them. And it's one of those facts that allows me to constantly be in touch with my patients.
Yeah.
And I'll call them and they'll be like, why are you calling me? I don't know, I just want to see how you're doing. How are you doing? I'm doing fine. Okay, no worries. And even like a few years after they come back, they'll say, my back hurts. My question is, are your legs hurting you? And they go, no, my legs feel great. Well, that's a success.
Yeah. Right. I like that breakdown because I think it's really interesting. I think for some people listening, maybe they don't realize as well that pain going down the leg, that is coming from the back.
It's coming from that, yeah.
Right, and so like when you're talking about pain in the thigh and pain in the calf and the knee and the foot, that radiating pain down the leg, that is spine related. And so you're not doing surgery on their legs when you're talking about that. You're talking about, we're going to do spine surgery either way.
Right.
But if it's focal or if it's focused on the back versus it's the back going down the leg, are very different things and have different prognoses or outcomes based off of that. So I didn't know that. So that's really good. So really high prognosis and potential outcomes for radicular pain.
For radicular pain, yeah.
Or radiating pain. Right. And lower, but not necessarily shouldn't be an option, but lower prognosis for people that are just having focal back pain. And most people that I talk to a lot of people have both. Right. They're like, well, it hurts in my back and it goes down my leg. Okay, great. So in that type of a scenario, that's maybe a better candidate. If they've failed all the other modalities, that would be a good candidate.
So for those patients that have both back and leg pain, there's actually an anatomic reason for that. So I don't know if you ever had sciatica. I had sciatica 2 years ago on my left leg.
Okay.
It's probably the most debilitating pain you'll ever have in your life. I wish it not upon anybody. It will put you on the ground. It's that bad. When patients have sciatica, what they end up doing is they start walking bent forward.
Yeah.
Because they're trying to protect their spine. So you'll see a lot of patients in the grocery store, and that's actually
grocery cart sign.
The grocery cart sign is real. It's in medical textbooks, but we got it from the grocery stores because you see a lot of these people walking around bent over.
Leaned over, yeah.
And the reason they walk bent over is because when they stand upright, it will kink their nerves, and the leg pain increases. So when they walk bent forward, it opens up their spine.
Yeah.
And so what happens is they have a lot of leg pain. Now they have back pain because they're walking like this for many years. So what I tell them is, I still tell them the number one goal of surgery is to heal your leg pain.
Yeah.
You will have leg pain relief in the first 2 weeks after surgery. Back pain will indirectly get better with PT and chiro 6 months down the line because now you can walk more upright.
Yeah.
So it's kind of like, you know.
As you're fixing the issue and then rehabilitating the spine.
Correct.
Yeah, that makes sense.
And I think that's where you guys come in, because you have to tell the patients surgery is not the hard part. Like, we do this day in and day out.
Yep.
We're like mechanics.
Yeah.
The hard part is the 6 months after surgery. Because if you don't rehab, if you don't do your exercises, if you don't stretch, if you don't strengthen, whatever I did is going to be a failure.
Yep. Well, and it's not really a failure that you didn't do a good job.
Right.
It's the fact that the body didn't heal because you didn't do the part after
Correct.
that was so important. So I think that's really important. But yeah, the grocery cart sign, I know that we have so many patients that, like when we talk about this, like, I see people like that all the time at the store. It's like, are you one of them? It's like, yes.
Yeah.
But, you know, to your point, when we see that, what it instantly tells us is we probably have some form of spinal stenosis.
Correct.
And that's what you're talking about. So spinal stenosis is, again, that narrowing of the spinal canal. And when we see that, that's why they bend over, create more space.
Correct.
When you create the space, the pain goes away. And so they're getting like neurogenic claudication or pain in their legs. They lean over, pain
better.
goes away.
Yeah.
Right. And so for anybody that may be feeling that is a sign of something else going on. It's important to say, well, I just have to lean over. It makes it better. It's nothing. It's like, no, it probably is something. That's one that I would say as we try to educate our communities. It's a really easy one to say, if you're experiencing that, really go to talk to your doctor.
Yes.
Explain what's going on, and it's pretty good outcomes with that specific condition with
Correct.
the surgeries that we have available for
Correct.
that. So, all right. So moving on then. So you focus specifically or mostly on the lumbar spine. Is that accurate, or do you
I
do
do
full spine?
50-50, so I do the whole spine,
Okay.
cervical, thoracic, and lumbar.
So what would you say is your favorite surgery, because it gives that almost immediate gratification you were talking about earlier?
Yeah.
The fact that you say, I know if I do this, I'm going to have a great outcome with the patient.
I would probably say the lumbar spine when they have slippage, like a listhesis,
Yeah.
spondylolisthesis. That is probably one of our more favorite surgeries to do, because once you put it back, you can actually see it intraoperatively coming back into place, and you have to put the screws in to lock it in place. From an anatomic standpoint, it looks pretty, it looks nice, it's beautiful. So I think from that perspective, yes, that is my favorite surgery. My favorite surgery of all time is the one I'm not doing, actually,
Really? What is that?
which is telling the patient they're non-op. That's the best surgery. The best surgery
This is
in
a
the
surgery
world.
you don't have to do.
Is best surgery in the world is a surgery you're not doing on a patient that doesn't need it. That's the best surgery you can do. And honestly, like, you know, you've been in the same field as I have, probably longer than I have. You will have complaints where patients will say, well, he's not cutting me open. And I take that as a compliment.
I like
Because when
that.
somebody says, you're not cutting me open, you're a bad surgeon, no, I'm actually preventing harm. And I take that as a huge feather in my hat, that I'm not cutting you open. Because you need to understand there's reasons why I'm not doing it. Luckily, you also know these physicians. We're in a field, especially Scottsdale era Phoenix, where a lot of the physicians are pretty good, ethical,
Yeah.
by-the-book spine surgeons. And if you poll 9 out of 10, who are my friends, they will say the same thing. This person should not get surgery.
Yep.
And that makes me feel really good when I don't operate on them.
We have great doctors in Arizona. I agree
Right.
with that.
That's something we got lucky with. Is our spine community is phenomenal.
Yeah, it really is.
Yeah.
And again, it's funny because I say this. There's like this thing that says, like, if a chiropractor is telling you to go to an orthopedic surgeon, you should probably listen, because normally they're going to do everything they can to not get you to go
Keep
there.
you- yeah.
Right? And it's the opposite's true. It's like,
Yeah.
if an orthopedic surgeon's saying you don't need surgery, that's a
Listen.
good thing, right? Like that you don't need surgery. And so it's this thing that when somebody who normally wants to use their modality and their treatment for you is telling you, no, this isn't the right thing for you,
Right.
like that means that they're probably right.
I think it's
Right.
also the culture we live in is like, you know, we have come from a society of like 1940s, 1950s, where I'm an old man in a young man's body.
Okay.
So I like the idea of working hard and, like, you know, grunting it and just bearing with it. I think our entire culture in this country has shifted, where we want instant gratification. So if somebody says go see a surgeon, automatically before you even see the surgeon, in your head it's like, well, if I get surgery,
This will go away.
I'm going to be fixed.
Yep.
Well, two things are wrong. Number one, just because you're seeing a surgeon does not mean you're getting surgery. And two, you can't get fixed.
Yep.
I'm religious, so what I tell my patients, God fixes. I make you better. I'm not a God. I'm an engineer. So I cannot fix you. I cannot make you younger. I can make you better than you are today.
Interesting. There is in healthcare, specifically in orthopedic surgery, there's a thing called the God syndrome.
Yeah. Spine surgery, yeah.
Yeah, in spine surgery, right?
Not so much. I'm kidding. But there's a lot.
It's basically like, I will fix you. And so
Right.
you're saying that you don't have that, and that the only person that can really do that is God. I love that.
I've never used the word fix in my entire medical career. I actually stop patients. When patients say, let's get fixed, I'm like, don't say that to me. But there are two words in spine surgery you never use, 100% and fix.
Okay.
You have to tell people I can get you to 99.9%. 100% is up to God. And I cannot fix you. God fixes. I make you better.
I like that. I like that. Because again, we're going to do everything we can to help the patient be on the best track possible
Right.
for relief. But there's a lot of other factors. What do they do? Like, are they eat like nutrition? And again, like you just said, of like, there's that other factor which I think is awesome to attribute to God. So as we look at whole body and everything like that, you obviously work with a lot of different other providers to support the patient outside of what you do. What is some of your best advice to patients that say, kind of in the condition that you just talked about, I've got this back pain, it's going down my leg, it's really bad, I want you to fix me, like, because that's what they're thinking.
Right.
You're going to fix me. How do you have that conversation of, like, what I'm going to do may take the pressure off the nerve, but that's the start, that's not the end. You
Right.
now need to do the physical therapy and the rehab and the spinal rehab. How do you have that conversation with patients?
So a lot of times I will actually have them see the therapist beforehand, before the surgery.
Establish the relationship.
Because I want them to kind of go through a few regimens of exercises with the therapist. And I tell my patients that the most important person in this entire cycle is actually going to be your therapist. I come in temporarily when I operate on you, and yes, I am important in that facet of surgery, but your relationship with your therapist has to be solid. And usually we do therapy. I personally, for lumbar spine fusions, will have them do therapy for at least 6 to 9 weeks, 3 times a week. And it's hard for them to do that because they're like, I don't want to keep on driving it. And I tell people, listen, Arnold Schwarzenegger was onto something. It's like no pain, no gain. Like, you have to put work into it.
I mean, that's where we mostly see non-compliance in that realm. Is it's hard and sometimes it's painful.
Right.
Right. And the one thing that you can tell from patients that are coming into any type of pain management, chiropractic, physical therapy, they're looking to avoid pain,
Right.
not to do more pain. And so that is one of the biggest areas we see with compliance drop off. There's 2 areas, actually. I would say there's 2 areas we see compliance drop off. One is that it's hard,
Yeah.
and it may be painful to do that. But the other one is actually really interesting, is they start to feel better. And so they stop before they should. So for example, you will almost always have a decrease in pain before you have good core strength.
Yes.
Right? Because as the core starts to get stronger,
Right.
your pain starts to go away. And then you go, oh, I'm better. I don't need to do this anymore. But if we actually do functional testing to test the strength of your core, it's going to fail.
It's going to fail.
Right?
Yeah.
And so one of the most important things I think for patients is to realize, don't stop because something's working. The fact that it's working means you should continue to listen
Right.
to your provider until they say, you know what, we can now show objectively that your core is stronger, it's more functional, you're going to be in a better place. And until that provider gives you that thumbs up, continue to listen to your doctor, because they do go to school. They know
Yeah.
how to measure these things, and I think that's really, really important. You know your body better than anybody
Right.
else, but your provider is going to know how to help your body.
Well, I think that
And
also
that's
is like, I try to go both into like the physical aspect and the chemical aspect, because you have to tell patients, when patients have back pain, what is pain? Pain is nothing but your body's response to chemical stimuli.
Correct.
I can get into details, but I'm sure you know this one already. You have chemicals that are released when you have a pain stimulus.
Yep.
Your body's nerve endings pick up that chemical and go to your brain to tell your brain, I'm in pain, right? And so when people say, mind over matter, yeah, there's an actual certain anatomic truth to that. But those chemicals that cause pain in your body can go away on their own in 3 to 4 weeks.
Yeah.
Which is why usually in 3 to 4 weeks after, let's say, I don't know, you picked up something heavy and your back spasmed, in 3 to 4 weeks you're going to start feeling better. You cannot stop exercising. The reason is because your core takes 2 weeks to atrophy. So while those 4 weeks you were waiting to have the chemicals go out of your system, your core is already atrophied. And so you're correct. So at 4 weeks when they start feeling better, they'll say, I don't need this, I'm done. I don't even want to exercise. Well, now you're really screwed.
Yep.
Because for 2 weeks you did nothing. For another 2 weeks you were healing. So now you have 4 weeks of no core exercises. And now you're feeling better, which you should.
Yep.
But this is the time you need to take to exercise.
Yep.
Because this will happen again.
Got to get back to where you are, or it's going to be a cycle, like you just said.
It's a cycle.
It's going to happen again, and then you're not going to do activity.
Yeah.
And then you're going to say, hey, I can do more, and you're going to go jump back into it,
Right.
but without core stability, and then you're going to hurt yourself, and then you're going to go, oh, I can't do that.
Right.
And that's one of the biggest things that we see in patients is the limitation of life to try to avoid pain.
Right.
Right? And so patients will come in, and their stories, I think, are really important. I used to be able to golf, but my back started to hurt, so I don't golf anymore. I used to go walking with friends, and my back started to hurt, so I don't walk with friends anymore.
Right.
I used to do X, Y,
Avoidance.
Z, right? And so they start to limit their life to avoid pain rather than saying, hey, there's actually a better solution, right? If we can strengthen you and if we can do rehabilitation and we can make it to where you can do those activity pain-free, that's better. Getting your life back and doing all those things is a lot better than just avoiding them to avoid pain, because there are real solutions to these pain conditions when you treat the root cause. You don't, this is Doctors Unscripted. One of the main reasons that it's called Unscripted is obviously, we're just talking. But the other part is we do focus a lot on non-opioid care, like covering up symptoms with medications when you could treat the root problem. Right. And so it's really to say there are good solutions. There's great doctors in our community. Talking to your doctor, talking about those options that you have, rather than avoiding, things that are painful, is a lot better track to have a healthy community, have a healthy lifestyle, and to get your life back. And so, and that's one of the most important, I feel, pieces of patient education we can get out there, is there are solutions out there if you're experiencing pain.
Right.
So, all right. So last couple of things. I know you talked about this at the beginning, which I love, is that you would have been a chef if you weren't an orthopedic surgeon. So what is it about food and culinary and that type of thing that really interests
It's like
you?
the serving people. It's fun.
Is it something about, like, because you talked about instant gratification, is not instant gratification, but non-delayed gratification. Do you feel like whether you take somebody to a great restaurant, whether you cook something and you give it to them, that feeling of I present something and they taste it, and it's like that smile that comes on their face, there's a similarity with that of being able to say, I can do something to make you happy, an orthopedic surgeon, which is I can do something that's going to improve your life. Do you feel like there's a connection for you?
It's quite similar. I think, look at all the ways we deal with depression. We always tell people go for a nice restaurant, get a nice meal. A lot of times the nicest meal in your life is what gives you the best emotions. And that part of being a chef is what really made me want to do culinary school before I looked at the economics of it. But that's that part of serving people, making people happy. And yes, having that instant gratification of watching people smile and say, oh my gosh, this was the best meal, I hope, or this was the worst meal I've ever had. So either one.
It gives you feedback.
Gives you feedback, you get better next time. So that's what drew me to culinary school.
Okay. I love that. Like talking to the doctors that we have on the podcast and hearing about their backgrounds, there's oftentimes a similarity to either service, a similarity to like really enjoying working with their hands, and lastly of really being passionate about community and helping. And so I love to hear the stories of our doctors that come on to hear that. So in the spirit of Doctors Unscripted, one of the things that we really like to ask anybody that comes on is, how do you feel we can help solve the opioid epidemic as a doctor community?
Convince people there are other ways of dealing with pain than opioids, and that using opioids in the right circumstances is appropriate. However, the generic use of opioids, while in the moment might seem as instant gratification, down the line is poison.
Yeah, it's not the right thing to do.
You are getting addicted to poison. Our country, unfortunately, the media is powered by big pharmaceutical companies.
True.
I hope a lot of patients look past that media, look past these ads
The
that
marketing and
market to their brains and look to their physicians. And I hope that as physicians are getting older,
excuse me.
they are more independent of these big pharmaceutical companies and are providing patients with the same advice you would give your mom and dad. You wouldn't want your mom and dad to be hooked onto opioids.
Nope.
Why would you want that for your patients?
Absolutely. And that's why we focus on that, of saying we want to do everything we can to get you off of opioids. In fact, that's one of the ways that we're different as a pain management group. We're multi-specialty pain,
Right.
But the reason we're multi-specialty is we say we're going to use all these other modalities to either go to first so that we don't have to do that,
Right.
or if you come over on an opioid, we're going to get you off.
Get you off.
Right? And I think that's like one of the most important things about pain in general is we need more practices that focus on getting people off of opioids rather than putting people onto opioids.
Right.
Opioids have a place, as you said, but like our number one goal once somebody's on opioids should be what's the pathway to get you off.
Right.
Right. And I think that's important.
I think even with surgery, a lot of my patients, when I do my preoperative visits, I tell them that I don't want you on opioids. Please try your hardest to get off of these things.
Yep.
If you had to use supplemental medications such as CBD,
Yeah.
use it. Use muscle relaxants, but get off narcotics. And I think the communication with your patients before surgery
Set the
helps them
expectation.
set expectations after surgery. And yes, I think a lot of my patients that are not on opioids after surgery, I actually have them write testimonials on
about that.
North Arizona, not to like applaud the surgery. Forget that. I want you to talk about how you did not use opioids after surgery, that you are that person, and how did you do it? Tell other patients that.
Share those stories.
Because it is possible,
Yep. I actually really like that as a model for changing the opioid epidemic.
Right.
Which is make sure that we're having patients that are getting relief without opioids share their stories.
Correct.
So that our community can know that is an option for getting relief. Because unfortunately, as you said, there's this giant marketing machine
Right.
that wants people to get on.
Yes.
There's a lot of money to be made by getting people on opioids.
And drugs in general.
And drugs in general.
Yeah.
And so the one way we can combat that really well is to give our patients voices for if you're getting better without it, you need to share your story so people know it's possible. Because once they know it's possible, they can know that's what I want.
Yes.
And they can seek that instead of, if that's all you know is that opioids are going to give you relief, of course that's what you're going to look for, because that's all you know.
Correct.
And so what a wonderful way for us to be able to combat that. That's one of the reasons we do this podcast, is really to be able to say, how can we continue to educate our communities and really make healthcare more understandable, more approachable, and hopefully messages like this get out there to where people go, it is possible to get relief from pain, treat the root cause, and not have to be dependent on opioids. So I love that. All right. Well, thank you so much for coming in for the podcast today. Like, incredible stories, and as always, our interactions, working with you have been great. So again, thanks for coming on, and
Awesome.
I'm sure we'll talk again soon.
Thank you.